So good morning, ladies and gentlemen. It's my privilege to have you here today at the Orthopedic Grand Rounds. Today's topic pertains to lungs and long bones, and it's a matter of survival. Bones are frequently thought of as an innate structural entity without any vitality to them. But anybody who knows bones knows that they're filled with blood. They're like an organ system. And while bones provide necessary structural support, they also provide vital support for us, and under certain circumstances may actually turn against us. Here to discuss this very interesting interaction today are a number of colleagues. Josh Lindsay, PGY4, will take us through epidemiology. We have Dr. Daphne Beingessner, Assistant Professor of Orthopedics, to talk about orthopedic aspects, and we're particularly privileged to also have Dr. Margaret Neff, Associate Professor from Internal Medicine, and well known to all of you at Harborview as one of the directors of our ICU system, which, by the way, is very full right now. 86 out of 88 beds, I'm told, are filled. But Margaret Neff will take us through the pathophysiology and educate us on those. So Josh, why don't you take the lead here?
Thank you, Dr. Chapman. Again, I'd like to thank our faculty experts for joining us today. I'd like to begin our discussion today by presenting two separate cases which are relevant to our discussion. The first case is a 30-year-old female who was in a car versus pedestrian accident. She sustained multiple injuries, including a perforated bowel, a right pneumothorax, as you can see here with the chest x-ray, cervical spine fracture, and bilateral femur fractures. One of those fractures was open. She was taken emergently from the emergency room to the OR, where her abdomen was washed out, packed, and then she went to the ICU, where distal femoral traction pins were placed. These are spot films of her AP views of both her femur fractures with traction in place in the ICU. The second case is a 20-year-old male who was in a motocross accident. He sustained a left femoral shaft fracture. He was admitted to the orthopedic service, placed in traction. So the questions that I would like to discuss or raise today with our discussion are, how should these two patients be treated, or patients in general with long bone fractures? Are these patients at risk for complications related to their long bone fractures from a pulmonary standpoint? What are potential systemic pitfalls of these injuries, and how can we avoid and prevent these and treat these problems? And how should these patients have their fractures fixed? And also, we'd like to discuss timing. When should these patients go to the operating room? This is a general outline. I'm going to give a brief history of femoral shaft fractures and treatment, in addition to the introduction to the concept of damage control and damage control orthopedics, followed by a brief discussion on fat emboli, which will transition to Dr. Neff talking about pulmonary complications, a coordination of care, and Dr. Beingessner will follow with surgical considerations. At the end of this discussion, we'll revisit those two cases that we presented earlier. So a brief history of femur fractures and their treatment. The initial treatment for femoral shaft fractures was traction, and this was largely the standard until the mid-1970s. Patients were placed in traction using ropes and pulleys, and they were maintained in bed for weeks to months until their fractures healed. Although there's a high union rate, there were complications associated with this treatment, both from a local standpoint of wound breakdown, decubitus ulcers, and problems with perineal care, but also from a systemic standpoint of deep vein thromboses, pulmonary emboli, pneumonia, and then diffuse muscle atrophy from being bedridden for months. Afterwards, they also had problems with stiffness of the ipsilateral knee. Although this treatment worked, it was what we had at the time, and there was a fear related to treating fractures open before the antibiotic era. Shortly after the introduction of traction, internal fixation was introduced, and Dr. Kuntscher is credited as being the founder or the godfather of intramedullary nailing, which began in 1939 and 1940 during World War II. After this, the AO Foundation was formed, and the AO principles were adopted, which include rigid internal fixation, anatomic reduction, and early mobilization of patients. In the early 80s, and continuing into the 90s, there was this concept of early total care. So patients who came into the emergency room, such as our first patient, would go down to the operating room that night for definitive care of all her injuries. There was a shift in mentality from this patient's too sick to have an operation to this patient's too sick not to have an operation. This did very well for some patients. However, not all patients did well. Some of the problems that these patients were faced with were fat embolism syndrome, acute respiratory distress syndrome, and multi-organ failure. It was difficult to predict which patients would do well and which ones would not. Damage control orthopedics. Damage control is a naval term which is used to describe all means necessary to keep a damaged ship afloat during the time of war until it could be repaired at the port. General surgeons initially adopted the concept of damage control to their literature when looking at patients with penetrating trauma. It was quickly realized that patients who had had a penetrating wound would benefit from going to the operating room for a quick washout and stabilization of their bleeding, then have them go to the ICU before coming back down for a definitive repair once they're physiologically stabilized. Orthopedics then adopted this care. So what is damage control and damage control orthopedics? It's the concept of early stabilization of injuries with delayed definitive fixation until the patient is physiologically optimized. What it's not, or what people misconceive the concept of damage control orthopedics, is treating everyone in external fixators. External fixators are a means of treatment, but the goal of those are to temporize the injuries until the patient is physiologically ready. You must be aware of the systemic pitfalls related to this kind of treatment, and there has to be a coordination of care amongst the different services. Now I'm going to discuss briefly fat emboli. Looking through the literature, fat emboli was a large concern for orthopedists now, but more in particular during the early days of introducing internal fixation. Approximately 90% of trauma patients have some form of fat emboli in their lungs at the time of their injury. Between 12 to 26% of patients who undergo an intramedullary reamed nailing develop some type of pulmonary complications. This can also occur during total hip arthroplasty with long stem prosthesis. Approximately 1 to 5% of patients who have trauma will develop fat emboli syndrome. So where did the fat emboli come from? There is a study done looking at patients who died within 4 hours after blunt trauma. At autopsy, there was a universal increase in fat content in their lungs. However, there was no evidence of myeloid tissue within the emboli. There was no hemopoietic cells. Are fat emboli common? There's several studies, a lot of them have been done in animals, but basically intravenous sampling during the reaming process increases the amount of fat that's excreted from the canal during operative fixation. This is also demonstrated on intraoperative transesophageal echocardiograms, which confirm microembolic events during reaming. Then another question is, what is fat embolism syndrome then? This is defined by GERD, and there's different ways to diagnosing this problem, but it's a systemic response to fat emboli. You can either have 2 of the 3 major criteria for diagnosis, or 1 major and then 1 of the 8 minor. The 3 major criteria, which are the most pronounced or the most classic of fat embolism syndrome, include a petechial rash, usually along the axilla and the trunk, presenting usually in 48 to 72 hours after the insult, respiratory symptoms plus bilateral signs with positive radiographic changes, and cerebral signs or neurologic injury, which is unrelated to trauma. The minor features, unfortunately, are pretty common for a lot of trauma patients, including tachycardia, pyrexia, retinal fat, and petechiae. Then there's other things that aren't as common, such as urinary fat globules, sudden drop in hemoglobin levels, thrombocytopenia, elevated ESR, and fat globules in the sputum. So what's the difference between fat emboli and fat emboli syndrome? That's largely hard to say. They looked at this using bronchoalveolar lavage. In patients with fat emboli syndrome, they had an increased number of cells, in particular macrophages and neutrophils, which contained fat droplets in their samples. This was as high as 63% of these samples contained these cells with fat globules inside, versus 2% of controls or patients who had pneumonia and not fat embolism syndrome. In an excellent study, which looked at a combination of all these factors, intraoperatively, during an intramedullary nail placement, the patients underwent transesophageal echocardiogram to try and quantify the amount of fat that was being released from the canal at the time of reaming. As you can see with the diagram here, there was several different ways to quantify the amount of fat that was going to the lungs, but essentially some people had no detectable amount. Some people had what they called a snowstorm of fat emboli that were going to the lung during reaming, and others actually had large clots between 1 and 4 centimeters in diameter. The results of the study were very interesting. An increase in the number of emboli did increase the incidence of fat embolism syndrome, and a bronchoalveolar lavage, the increased number of neutrophils helped diagnose fat embolism syndrome. However, an increase in fat in bronchoalveolar lavage did not correspond with fat embolism syndrome. At this juncture, I'd like to introduce Dr. Neff, who's going to begin talking to us on pulmonary complications in the orthopedic patients.
Thanks, Dr. Lindsay. It's actually a pleasure to be here and have an opportunity to actually talk to you all about some of the pulmonary complications that we all see in these orthopedic trauma patients. I think whether I'm attending on the consult service and working with you guys in floor patients or taking care of patients in the medical or surgical ICU, we all recognize that a lot of these patients, particularly like the first case that we heard about, can be some of the most complex that we really care for in the hospital. And there's no question in my mind that it's when we're all working together and communicating and actually understanding what each other's challenges are that we have the best outcomes for these patients. This is a great opportunity, and thank you, Dr. Chapman, for inviting me to come. What we're going to chat about today are just a few things. Basically, the clinical presentation of some of these patients who were seemingly doing okay, then all of a sudden start having respiratory problems, be it on the floor, in the ED, intra-op, or in the ICU. Some of the things we're thinking about in terms of differential, and then medical management, and then this concept that I really like to think about, coordination of care. So certainly at any point in the context of their injury, you can have sort of these sudden onset of symptoms, but certainly most common, probably where we're seeing them, are in the post-op patient or sort of like post-injury trauma patient. And some of the common problems that we're really dealing with are hypoventilation as a possibility for why all of a sudden somebody who had been doing fine is now a little bit hypoxic, having an increased oxygen requirement, or just looking in distress. So hypoventilation, perhaps in part due to sedation from pain management, atelectasis, maybe even aspiration, whether related to their original trauma, or because, again, say if they're a little bit older or having trouble with their airway. Pulmonary edema, which unfortunately all the films that I'll show you could be anything. Fluid in the lungs can be from a cardiac source or from all these sort of systemic symptoms that we're talking about, be it sort of a general SIRS or inflammatory response to injury, and it can look a lot the same, but clearly we want to identify early on if there's a cardiac etiology. Pulmonary embolism, acute lung injury, and then fat embolism syndrome, which we already touched on a little bit. So when we're first sort of presented with a patient like one of the two that we just already heard about, some of the things that we'll do with an acute change in sort of their respiratory status, we'll start at least with some of the imaging, right? I mean, if we have an x-ray and it was totally clear when they first came in and now all of a sudden we have a really focal opacity in one part of the lung, that may be enough to help us understand, particularly if you add a little bit of a white cell count bump, a fever, something else that looks really to be consistent with an aspiration pneumonia. But recognizing that these patients have really, really high risk, many of them, for pulmonary embolism, if the film really doesn't explain it enough of the cause for the worsened respiratory status, we have a pretty low threshold for a CT pulmonary angiogram, which is probably our first approach for trying to identify if there's a pulmonary embolism. Recognizing that the ability to transport the patient to radiology, the ability for the patient to tolerate contrast, all have to factor into that decision. Sometimes things even just basic labs, all things that we'll be getting when we're starting to first evaluate this patient before we even have any of the imaging or other diagnostic testing. An arterial blood gas, if there's an arterioalveolar difference, so showing that there's kind of a big problem either in dead space or shunt or diffusion, that may help us kind of understand that, yes, this is more than just hypoventilation. This is actually something going on with the lungs themselves or the vessels. Again, if the white blood cell count is elevated, that may help actually give us a little bit of a clue. And then certainly other evidence of either a worsening metabolic acidosis, either by lactic acidosis or on a basic metabolic panel. If their bicarb is dropping, if we're having evidence that actually they're having worsened sort of acid through their system and actually resulting in sort of acidemia. We'll look at all their medications. Did they just get a ton of Dilaudid? Are they on a PCA and have just been pounding it and maybe on an infusion rate? All those things are good. We need to have pain control. Those are very important as well. But every so often, people react, obviously, as we know, in different ways to different medications. Could that be the source of the problem? We'll kind of look at that. And then certainly trying to get a feel through EKG and cardiac enzymes for any cardiac driver for the problem. And the theme really with all this, right, is to kind of try to get a feel for what are the most life-threatening events that could be causing this, identify those, treat those, and then move forward. So just to give you a feel for what some of this imaging can look like, here's day one for a patient much like the first patient that Dr. Lindsay described, a young woman who had multiple orthopedic fractures, multiple long bone fractures. And when she first came in, actually, this is day one, film not so bad, actually pretty close. I mean, for most of our ICU films, this would count as pretty much darn normal. But actually, there's a little bit of edema, actually, in the left and the right side of the lungs, but overall, actually pretty normal. And she had a CAT scan as part of her initial trauma workup. Heart, spine, this is the bone part in the back. So that's actually all normal. And the lungs, it all relates, right? I won't say most importantly. They're all, everything relates together. But the lungs really with no focal injury. We're not seeing a lot of contusions. We're not seeing a lot of pleural fluid. We're not seeing actually other injuries. So pretty good on day one. That drove the decision to actually take her to the operating room. She was pretty stable. Right around the time of her surgery, now we got a film that in the right side here, much more of a focal opacity in the right base, starting to make us worry about perhaps an aspiration pneumonia. And then also just on both sides now we have more fluid. As CAT scans over at the time, again, concerned about pulmonary embolism, really abnormal, quite different from the prior one. Now we have essentially opacities in both sides, and then obviously air where it shouldn't be. We've got pneumomediastinum as well as a left-sided pneumothorax. And then by day 3, so post-operative day 1, now diffusely opacified bilaterally, which we basically call as bilateral opacities consistent with edema, pneumomediastinum, and now she's got chest tubes bilaterally. So quite quick, right? If we look at it kind of in series, this didn't take long to happen, right? This was in about a 24 to 48 hour period. And this really drives the issue for all of us, right? How do we pick the timing, best timing for surgery? Is there a way to avoid any of this? And how do we actually kind of proceed in the management of these patients? So although when we kind of look back and we're talking about sort of that list of issues that actually can cause problems and acute respiratory failure, we're again clicking off and trying to be sure that things like pulmonary embolism, cardiac disease, hypoventilation, sort of medication complications aren't driving any of the problems. But two of the things we're going to talk about with a little more detail are acute respiratory distress syndrome or acute lung injury. And if you hear me kind of waffling back and forth between those two terms, we use them somewhat interchangeably. It's just a virtue of hypoxemia being a little bit worse in ARDS. And then we'll talk a little bit about fat embolism syndrome. So ARDS was first described in the 60s, so 40 plus years of actually recognizing this syndrome. And basically, just by virtue of being described as syndrome, it is just a clinical recognition of clinical findings. So bilateral infiltrates on the chest x-ray, hypoxemia, and in the sense that it's not due just to heart failure, right? So it's not just that they're in LV dysfunction, they're having LV dysfunction, they had a big MI. This is some other kind of systemic process. And that really gets at this concept of sort of alveolar inflammation, right? So it's not just about direct injury to the lung. This is actually about having inflammation, having white cells, neutrophils actually in the lung itself, and then also injury to both the endothelium, so the vessels, and the epithelium, so the airway wall. In an attempt to try to make sure we're all sort of talking about the same thing, so that if we're doing a study or actually comparing outcomes at different centers, there was an attempt to kind of standardize the definition. And basically, there are 3 components to this. So on chest x-ray, there are bilateral infiltrates on the chest x-ray, just like we saw on the prior case. The PaO2 to FiO2, so just one divided by the other, or P to F ratio, as we often refer to it, is less than 300 for acute lung injury, less than 200 for ARDS. And if you have to remember one number, I remember this one, which is anything under 300. So lower is worse, higher is good. If we put any of us on 100% oxygen, we'd have a PO2 in the 500 range. So basically, a high number divided by a low number is good. Basically means you're having really good oxygenation for a low oxygen requirement. But it doesn't take much to meet these criteria, right? If you think of somebody with a PO2 of, say, 100, even on 50%, that's still a P to F ratio of about 200. So it's still, it doesn't take even numbers that we look at and think, oh, those are pretty good. There's often still some gas exchange abnormalities. And then the last piece of this is just no evidence of left atrial hypertension. And in the day when we used a lot more pulmonary artery catheters or Swan-Ganz catheters, it also meant it was defined more by a wedge pressure or filling pressure less than 18. We don't use necessarily always the invasive devices now to identify that. So what we really want to just think about this is that it's something that's actually causing a problem with this systemic problem, and it's not due to just heart failure alone. So that's kind of how we ultimately operationalize that. Proven therapies for ARDS, so we've had 40 some odd years. You'd think we'd have plenty of time to kind of find a solution to some of this. We've actually got one intervention that's actually shown to have a mortality benefit for treating patients with ARDS. And this came out of a network of ARDS centers, the University of Washington, Harborview being one of them, to actually look at if there were actually mechanical interventions, let alone medications, that could actually help this. And the term we often use and that you'll hear people use at different centers is lung protective ventilation or low tidal volume ventilation. So it's a tidal volume of about 6 mLs per kilogram. This is based on predicted body weight. So as you get bigger and taller, your lungs grow. You don't get bigger lungs as you get bigger this way. You get bigger lungs as you get taller. So it's really based on height and gender, not necessarily on their admit weight. So you'll kind of sometimes hear us talking about this 6 per kilo, 8 per kilo. It's all about dosing tidal volume, almost like we dose a drug. And then we're also trying to keep their airway pressures kind of under a sort of a higher level of 30. So we're trying to avoid additional barotrauma to the lung. And for 30 some odd years, we had really no intervention that worked. Now we've got an intervention that has resulted in about a 22% reduction in mortality. We've gone from the 60% mortality range down to, years ago, down to about 40% when we started doing these trials, 30% or so now, and most of the studies are in the probably mid-20s now. Still pretty horrendous, but actually an improvement. Trauma patients in general have even a better mortality than that just because they are not sort of stuck with all the other comorbidities. So thinking about sort of ARDS versus fat embolism syndrome, it'd be nice if we could sort of, particularly if you guys are taking care of a patient and you're saying, could this be fat embolism syndrome? And you'll see us kind of scratching our heads and thinking, well, it could be. And you're thinking it'd be nice to actually know if they do, because what am I going to tell the family? And in reality, the brutal reality of this is that we can't honestly tell the difference. Clinically, they look a lot the same. If you think about some of the films we've talked about in the presentations, bilateral infiltrates, hypoxemia, it's not heart failure, it's all going to look, unfortunately, quite a lot the same. They both present with an inflammatory systemic response, and the main difference really is what got you there. So we can see fat embolism syndrome sometimes even in some medical disease processes, but really the driver for this is often the trauma patient with particularly multiple orthopedic injuries. So Dr. Lindsay started talking a little bit about some of the diagnosis and approaches to fat embolism syndrome. It really, a lot that drives this is clinical suspicion. So if we have someone that was seemingly doing okay, didn't have a lot of other risk factors for ARDS or acute lung injury, didn't have a lot of transfusions, didn't seem to have an aspiration. Unfortunately, a lot of the risk factors for ARDS are the same as for fat embolism syndrome, but some of the things are a little bit different. So they might have an acute onset of hypoxemia with new infiltrates on the chest x-ray, so that could go for either. But also the things that are sort of a little bit more classic for fat embolism is sort of this concept of a rash, which particularly is in the axilla but can be throughout the body, and kind of sudden onset. And then some neurologic findings. This can be anything from just some confusion to almost total obtundation. There are some findings on MRI that can be a little bit helpful, not so much CT. The MRI, you can have kind of little punctate areas throughout the white matter in the brain. Sometimes it can look a little bit like diffuse axonal injury or shear injury, or even sometimes just anoxic injury. So you're having to then kind of look, well, if they didn't really have a mechanism to support diffuse axonal injury, they were never really hypoxemic, then this may fit a little bit more with emboli to the brain. And kind of as we often say, there's really no troponin for fat embolism syndrome. We kind of always are a little envious of our cardiology colleagues who actually at least have a blood test to send to help to diagnose, say, acute MI. We're really kind of stuck with that. We don't have that for acute lung injury, and we don't have it for fat embolism syndrome. It's really about putting together the whole presentation in this story. And as we heard earlier, fat emboli really are very common in any of these traumatically injured patients. So having emboli cruising around through the blood, even seeing it on echo intraop is not uncommon, but not all those patients develop the syndrome. Bronchoscopy may be a little bit more sensitive and specific in terms of actually diagnosing this, because you may see some intracellular fat that you might see elsewhere. And basically this means we go through the endotracheal tube if they're intubated and do a little washing of the lung and actually look at the cells with some saline. We do some washing. The problem is, and we'll talk about in a second, there's not a tremendous amount other than supportive therapy that we're going to do to manage these patients. So we really have to weigh the risk benefits of sort of providing an intervention where it may not change our management. And then the last piece is kind of the mechanism as well. What is going on? Do we need to go into the vessels and actually suck out a bunch of fat? Is it a mechanical obstruction or is it an inflammatory process? And really it's a little bit of both. Sometimes some of the emboli can be quite large and actually mechanically obstruct flow through the pulmonary arteries and the heart. The vast majority of this, though, is thought to be sort of a toxic reaction to the breakdown of fat when it breaks down into fatty acids. We've done a lot of studies. Many people have done studies in acute lung injury in animals, and fatty acids actually have been known to actually drive acute lung injury and precipitate it. So that sort of whole process, if you can imagine, then creating a lot of inflammatory process kind of throughout the whole body is probably a lot of what drives sort of the clinical presentation that we see. This is one sort of diagnostic test that may actually at least help us. This is actually just an ophthalmologic view of what's called Purchers retinopathy or cotton wool spots. We can see this with any type of emboli, though, right? But again, in the right setting, where you have sort of all these little spots that are actually basically the emboli causing occlusion in the retina, and it could be at least supportive of a diagnosis of fat embolism. So management is supporting their intravascular volume. If they're having cardiac dysfunction, particularly right heart dysfunction, we're going to be supporting them with their fluids, possibly inotropes. And treatment really much like ARDS. So we're going to be supporting them, their ventilation and oxygenation, and really moving towards a lower tidal volume approach on the ventilator. Despite how bad some of these films can look at how much ventilatory support they need and how sort of neurologically sometimes in some of these patients may be affected, most do really well. It may take some time for all this to resolve, but even the profoundly sick patient, the expectation is recovery if they can survive their initial injury. As I mentioned, mortality for ARDS has really been reduced over the past 10 to 20 years, and so the fat embolism sort of outcomes also track with that with marked improvement. And really what you'll be seeing us talk about a lot now and outcomes in a lot of our studies for diseases of critical illness are really looking at not only mortality, but some of these other outcomes like neuromuscular dysfunction. We know a lot of our patients in the ICU have muscle weakness, and that affects a lot of their long-term outcomes. They may come back and see you in clinic, and everything else is fixed. Their breathing's better, their fractures are fixed, but they can't get around. They're totally weak, they're wiped out, they're having trouble balancing their checkbook. Now, granted, well, many of us may have the same issue, but basically they may have some neuropsychiatric testing that would show they actually had some deficits. And you see that by asking about it and by actually following these people, which we're trying to do increasingly. And then post-traumatic stress disorder is a big issue, not only from the trauma, but just from the trauma being critically ill in the ICU. So these are some of the outcomes that we're now starting to see that we're following in these patients. And the last thing that we'll sort of transition to the next stage of the discussion this morning is really about coordination of care. And there really are no absolutes regarding clearing patients for the OR. I mean, we'd be great if we had a set of criteria that the 100% of patients will do well if they meet these criteria and none will if they don't. Unfortunately, nothing in medicine is quite that black and white. And it really is about communicating between the team caring for the patient, be it in the ICU, with the surgeon and anesthesia to kind of say, what is it that's the most life-threatening for this patient? Balancing the pros and cons of waiting. I mean, much like we heard in the early days where there was a lot of, just delay and people were kind of hanging out in bed for weeks on end. Clearly, even just smaller delays in that can sometimes increase our risk of not only venous thromboembolism, DVTs and PEs, but also pneumonia if they're having to be flat in bed or not being able to get up and walk around. So we have to kind of balance those pros and cons. But certainly a patient like the first one we heard about who has multiple injuries, very reasonable to try to stabilize temporarily, get them up to the unit, actually resuscitate them, and get them to the point then where the pros and cons can be balanced, and we can then work with anesthesia to identify how best, what the things we worry about in terms of their intraoperative case. Is there anything acute going on? Are they having an acute MI? That's rarely a great time to take anyone to the OR, so we'd want to identify and exclude that. But even so, if we have an older patient with a lot of underlying comorbidities, we'd probably want to be actually coordinating a plan with anesthesia for intraoperative monitoring to make sure that they're as stable as possible throughout that case. So right now I want to turn it over to Dr. Beingessner to actually talk about some of the surgical considerations, because these are the things that she and I would be talking about to say, well, what are the pros and cons of actually just going to the OR right now versus actually giving us a little bit more time in the ICU to get them physiologically stable. So I'll hand it over to you.
Thank you, and good morning, everyone. So I'm going to talk a little bit about the surgical considerations related to the care of these complex patients. We're going to talk a little bit about specific things we can actually do intraoperatively from an orthopedic standpoint. We'll go over a little bit of the timing and some of the history of how we got to where we are now from where we came from with timing of treating of these patients. And then what can we do kind of in the interim while we're waiting for these patients to be resuscitated in the ICU to look after these orthopedic injuries and not really cause any further harm to these patients. So one of the first things that we're always presented with is, should we ream a long bone in the face of pulmonary injury or even just in the face of a long bone fracture? And I think we know that probably the gold standard for a femur fracture is a reamed, statically locked intramedullary nail. And so the question that brings us is, well, is that safe in these patients that we've been hearing about with these multiple traumas? Fortunately, there's been lots of studies done on this topic, and probably one of the most relevant studies is this study from 2006, and this was done by the Canadian Orthopedic Trauma Society. Although the numbers aren't huge, this is probably one of the best studies we have that tell us that reaming is safe in the setting of these patients. And so they randomized patients to a reamed versus unreamed group, looking at patients with low and high ISSs. And really the bottom line of this study is that there was no difference in the rate of ARDS or mortality between the two groups. So reaming is likely a safe procedure that can be done in this group of patients. But that being said, is there anything that we can do intraoperatively with our reaming technique to hopefully decrease these number of emboli that these patients are seeing? So just a little bit of background on intramedullary canal pressure. Normal intramedullary canal pressure is about 30 to 40 millimeters of mercury. And we know with simply just manipulating long bones, placing an external fixator, or even just putting somebody into traction, we can increase that pressure to about 160 millimeters of mercury. And we know that with further manipulation of the bone, even just with the opening reamer that we use to open the canal, or just placing the guide wire across the fracture, that we can increase that pressure even to as high as 830 millimeters of mercury. And this would actually lead to increased number of embolisms. What's important is that after reaming has been completed, actually placing the nail doesn't really increase that pressure. So a lot of the harm that we do is actually early on is just making that initial drill hole or placing that guide wire. So what can we do with our reaming in particular to try and decrease these number of emboli? So remember, Dr. Lindsay talked about the fact that the increased number of emboli that we see increases your chance of getting a fat embolism syndrome. Dr. Mueller came up with this gap equation concept from fluid hydromechanics to design a better reamer. And what does that mean? This is a pretty complicated equation that he worked through, but the bottom line is that he came up with this reamer design. And what we're looking for is a reamer that has deep flutes, so that will decrease the amount of extravasation of fat emboli into the system. The older reamers that you can see on the top left had this thicker design with narrow flutes. And you can imagine that putting something like that, which is like a large plunger down the center of the bone, would increase your number of emboli. So what you want to remember is always to have a sharp reamer with deep flutes and ream slowly at high speed. And that will be the best reaming technique to hopefully avoid some of these problems. There has been the introduction of a new device known as a Reamer Irrigator aspirator, and what this device does is actually suction out the marrow contents as reaming occurs. So basically there's fluid irrigated into the canal through the reamer, and then a suction device is applied that will ream out or suction out marrow contents as this reamer is passed across the fracture. We don't have a lot of evidence yet in humans that this will actually decrease our rate of ARDS, but it seems like a good concept, just understanding where some of these emboli come from. These are two of the most recent studies looking at this device, and these are both done in pigs, and these are just studies that were done in 2010. The top study was from the Journal of Trauma. Basically, they found in their group of specimens that the number of embolisms per centimeter square was lower in the RIA group than in a traditional reamed group, but they did have the same rate of death or pulmonary complications in both groups. The second study was out of injury again from 2010, and this study showed that there was higher interleukin-6 levels in the traditional reamed group than in the RIA group. And what does this mean? Basically, there was an increased amount of inflammation in that traditional reamed group versus the RIA group. This is early promising work in this area. Although we haven't really extrapolated this to humans yet, it does show that potentially there may be an increased benefit of using some of these types of devices in this more sick population, or these patients with pulmonary complications or at higher risk for pulmonary complications. So that leads us to the question of when should we operate, and I think Dr. Neff did a really great job outlining some of the potential pitfalls of these patients. I think it's important for us to understand where we came from and to understand some of the history behind when we've taken femur fractures to the operating room, because I think we've been kind of all over the map with timing, and a lot of different studies have pointed us in different directions. So if we know what the history is, we can really understand why we are at the protocols we are today. So this is one of early studies from the late 80s by Dr. Bone, and this was a randomized trial looking at early versus delayed stabilization of femur fractures. And the bottom line from this study was that delayed fracture care led to increased pulmonary complications, increased ICU stay, and increased overall hospital stay and cost. So this is one of the early studies that led us to this early total care phenomenon where people thought, yes, we need to bring these patients to the operating room as soon as possible. But people also started to notice that some of the patients really ended up with some poor outcomes and high incidence of pulmonary issues. And so this is a study done from 1993 by Dr. Pape introducing this concept of damage control orthopedics, and this is kind of where a lot of this early work started from. And their study showed that in the presence of thoracic trauma and early fixation, we actually had an increased postoperative acute respiratory distress syndrome and increased mortality. So this was a real switch from some of the earlier work that had been done in this area and a cause for concern. And it was thought that potentially these patients would benefit from an early external fixation followed by delayed treatment. However, the same journal following year looked at a similar topic, and they found that delayed fixation in the presence of thoracic trauma actually increased your pulmonary complications. So obviously this kind of leaves everybody scratching their head of which direction are we supposed to go. And I think the important thing to take away from this is there's not really a cookie cutter concept that you can take from this that for fracture X on day Y, this patient gets a surgery and they'll have a better outcome. I think looking back at what Dr. Neff said, it's really important that we coordinate the care and make sure these patients are completely ready systemically for an operation, and it's not just picking a certain day that's the ideal time for fixation of these long bone injuries. And so that leads us to present, so to 2010, and what's kind of the standard of care, and what do we do at Harborview in 2010 to maximize our outcome of these patients. This is a study that came out at the end of 2009, and really the bottom line of this study was emphasizing that the preoperative resuscitation of these patients is the most important component of their care. So not rushing patients to the operating room that aren't ready for the operating room, but waiting until their pulmonary status is maximized if possible, that their systemic resuscitation is maximized. And again, despite this low use of so-called damage control orthopedics, these patients did quite well with relatively early nailing, or even some patients with delayed nailing. And the bottom line and the kind of common thing between those two groups was that the patients were maximally resuscitated. So again, we're moving away from this early versus late care to this maximally resuscitated care, and that's probably the most important concept to take away from this. The other important concept that Dr. Neff alluded to is this team approach. So we need to be in communication with our ICU colleagues and with our anesthesia colleagues so that we can discuss with them and they can understand why we think it's important to take this patient to the operating early, and we can understand from their standpoint the important things that need to be done in order to optimize these patients for the operating room. Like we heard about, though, if we're going to be resuscitating these patients even for several days, what should we do in the interim? Should these patients be placed in external fixators? Or should they be placed in traction? Or what's the best thing that can be done for these patients? The damage control concept really has been that all of these patients should get external fixators and then come back later for definitive fixation. At Harborview, we don't really do that very much. It's very rare that a patient gets placed into external fixators for their long bone fractures, and we tend to treat these patients in traction in the ICU, and probably an extra trip to the operating room is not warranted just to place an external fixator. A study just came out this year as well, 2010, looking at this exact question: is skeletal traction as good as external fixation for these patients? And this study actually showed that yes, skeletal traction is as good as external fixation preoperatively. There was no difference between these groups in mortality, ARDS level, and most importantly, there was no difference in these groups in local complications like decubitus ulcers or problems with care in the ICU. But once again, I think this is something that really needs to be coordinated with our other colleagues and to understand what the needs are. For example, if you have a patient with femur fractures that needs to be placed on a lung protocol that they need to be prone in the ICU, this may be a patient that an external fixator is warranted in. And so once again, you really have to be in discussion with your team to understand what is needed. So I'm not saying that external fixation is never needed, but I'm also saying that it's not always needed for sure, and it's something that you need to discuss with the patient and each patient, or with the patient's caregivers, and understand that each patient is individual and there's not sort of a set protocol for everybody. And so that leads us back into our cases that Dr. Lindsay will discuss.
I'll begin by summarizing patient 1. So again, this is a 30-year-old female who's in the car versus pedestrian accident. She had multiple injuries, including a perforated bowel and pneumothorax, in addition to these bilateral femur fractures, in which one was open. I'll start by asking Dr. Neff, what different parameters or issues are you looking at before allowing us to take her to the OR from a clearance standpoint?
I think, sort of as we've been discussing, I think a lot of the goal here is to make sure the patient's in as best shape as possible for when they actually get to the OR for whatever it is, whether it's actually to evaluate the bowel, to actually take them for the orthopedic fracture repair. And in these particular types of patients, often they're getting a bunch of fluid in the ED to try to kind of start actually that resuscitation, get them out of shock so that they can actually have a more appropriate timing for going to the OR. And things we'll be looking at to actually see if they're improving would be some of those laboratory parameters we were talking about, probably the lactate, which may have been high initially, hopefully starting to wash out a little bit and coming down, base deficit closing a little bit, and actually, hopefully, although they may or may not be intubated, if they are, that they're actually relatively stable on modest amounts of oxygen. And that's, I think, where some of the discussion really is the best that we're having together, because sometimes it's harder for us to know how critical some of the interventions are. We would love to have everyone totally perfect before they go to the OR, but that's not really realistic if the risk of actually leaving an open fracture for a long period of time without any sort of washout, any sort of intervention, is higher on the risk, then we can actually step back and say, well, shoot, they're only on 50% oxygen, they're tolerating their management pretty well. We actually think we can coordinate this with anesthesia. But then I'd actually talk to Dr. Lindsay, Dr. Beingessner, to actually say, how critical is this intervention? How good do they have to be while we continue to resuscitate, make sure they're not having acute problems. In this particular case, since a younger person, we probably don't have a lot of comorbidities that we're having to worry about, but we're wanting to make sure the hematocrit's stable, oxygenation at least stable, not necessarily having to improve, and that we're slowly starting to close that deficit and shock. And that can be within the first 12 to 24 hours.
Thank you, Dr. Neff. And then I'd like to ask Dr. Beingessner what operative considerations she has regarding this patient.
So like Dr. Neff referred to, these are patients that we would like to bring to the operating room as soon as possible with bilateral femur fractures, one being open. So obviously we'd like to do an irrigation debridement sooner rather than later. But again, understanding that we need this patient optimized. This is a patient with bilateral injuries, and so this patient is at increased risk for sure of developing pulmonary complications or developing increasing number of embolisms. This may be somebody that I would consider using a RIA for to hopefully decrease those number of emboli into their system. And then you also have to continually reevaluate. So if I'm going to be treating bilateral femur fractures, I may address one of them first and then check with anesthesia again and see how this patient is doing. And if the patient's still doing well and can tolerate further surgery, then we can go ahead and fix the second one. If they're really not doing so well, this may be somebody that now I've nailed the first fracture, I may wish to put the second one into an external fixator. So it's this real concept of continually evaluating the patient to see what they're going to tolerate intraoperatively. And then really picking the operation that I can do the most expeditiously. So if I can do an antegrade nail quickly in this patient, that would be the operation that I would choose for fixing these fractures. If somebody's more comfortable with a different type of nailing, say a retrograde nail or a different start point, if they can do that quickly and expeditiously for that patient, I think that that is fine as well. So really doing what you're best at for these patients, getting it done quickly, and then using all of the tools that you have available is the most important.
And I might just follow up on that with saying that I think the critical thing, even as we've been talking more, as we've been thinking about this presentation, is really recognizing what each of us does and the strengths and some of the issues that we're both struggling with in these patients, and actually figuring out a way to actually not make assumptions about, oh, they're going to do too big of a thing in the OR. There's no way he'll tolerate it, so I'm just going to say no to clearance for the OR. Well, there may be lots of options for kind of phased approaches or stages, and I wouldn't know that if I'm not actually communicating. And vice versa, it may look like they're horrendous because they're on more oxygen, but maybe that's actually getting better and we think they'll totally tolerate it. So I think if there's one take-home message, it is about not making assumptions about each other's sort of problems and needs, which I think we all do really easily. And because you just sort of get focused in your area. We get focused in the ICU. It's easy to get focused on the operative issues. And we got to kind of figure out where that middle ground is. I think we do a really good job at this, but I think it's what makes this work. And I think it also helps the patients that we get the optimal care at a time that they can tolerate it.
The concept of traction for all these femur fractures has sort of developed, it seems, from the long-term treatment to avoid shortening and so forth originally before fixation. And it's the gut reaction at Harborview to place all the patients in traction. Experience in the community is that this is a labor-intensive, resource-difficult process. And the vast majority of patients don't have delay of treatment long enough that they develop permanent shortening. That's a problem. Is there something about traction as opposed to splinting or Buck's traction for these injuries that is preventing a pulmonary problem or other? It can be actually sometimes more difficult to mobilize the patient in traction than in a splint.
We employ it for numerous reasons, a lot more than just simply shortening of the fracture. First and foremost, it provides significant comfort. So if you ask many of these patients how did they feel prior to traction being placed to after traction being placed, they feel significantly more comfortable with traction on. So I think that's one of the most important things that we can do as surgeons is to help our patients feel better. So I think that's first and foremost. Second of all, there's a lot of soft tissue damage ongoing from having a mobile femur within your thigh. So you need to do something really to stabilize these patients. And a splint may or may not be helpful based on the patient's size, but a lot of patients really are not going to get very much stability to a femur fracture, particularly a more proximal femur fracture with splinting alone. So again, splinting that long bone will prevent ongoing soft tissue necrosis, soft tissue damage, and I think will be helpful. Thirdly, it's really quite a portable treatment where you can hook up traction to the end of a stretcher very easily. It can be hooked up in the CT scanner. So really it's not a difficult or expensive thing to do, and overall it really does benefit the patients. And finally, having something pulling on the bone will decrease that amount of motion, and just simply motion at the fracture site can increase your number of emboli that are going across. So having somebody with decreased motion at their fracture site really can decrease their chance of getting lung problems. So really traction is a great option. Traction, this is different traction than used in the 70s where it was used to actually treat fractures. This is something for a short period of time, but I think patient comfort is probably the most important thing that we can provide.
And then our last case, which we discussed earlier, was the 20-year-old male with a motocross accident with an isolated femoral shaft fracture who was admitted to the orthopedic service in traction. I was going to ask Dr. Neff, is this patient at risk for any complications related to this fracture from your standpoint?
I think the vast majority of patients like this I never even see because they do great. They come in, they're on your service, they go to the OR, they start recovering and rehabbing shortly after. And it is a smaller population, probably not terribly well quantified, but we know that when we look at sort of the risk factors for, say, acute lung injury, long bone fractures are right at the top of the list. Well, trauma is right at the top of the list along with sepsis, and among the trauma patients, the multiple long bone fractures or even a single long bone fracture like a femur fracture is a risk. So all you can do really is sort of be sort of aware and on alert, and essentially the vast majority of these people will do fine, but the things that this patient would still be at risk for, we certainly pulmonary embolism, fat embolism is still an issue, and then sort of all just the other complications you can get just from being sick in a hospital, not moving around as much. So sort of being aware and trying to have preemptive strikes for anything that we can to avoid subsequent complications. But we do still worry about these folks, and we do still see them with those sort of presentation of acute respiratory failure, like we talked about at the beginning, where then we'd be just sort of checking off the list to exclude sort of the life-threatening things and continue to support them.
And then Dr. Beingessner, what operative considerations are you considering when looking at this patient?
So this is a fairly standard femur fracture, something that we see quite routinely. I think it's important to remember, you think this is just an isolated femur fracture. This patient still is at risk of having significant blood loss in their thigh, so they may have a large hematoma present. which may also make them be under-resuscitated preoperatively. So this is somebody still that even though they're not presenting like a multi-trauma patient, you still have to make sure this patient's adequately resuscitated prior to going to the operating room. I have seen patients with isolated tibia and femur fractures develop quite profound fat embolism syndromes, and so it's important to keep that in the back of your mind and still worry about these patients and resuscitate them adequately. Intraoperatively, this patient would probably get a very standard operation of a reamed, statically locked intramedullary nail, again using those proper reaming techniques that we talked about earlier.
Let me ask a question to both Dr. Beingessner and Dr. Neff. Hypothetical scenario, all things being equal, isolated femur fracture, no other organ systems diseased with morbidity or trauma in a 16-year-old patient, case A. Case B, a 80-year-old lady with significant osteoporosis, and what I'm hinting at is a very fatty bone marrow. Who is at a higher risk of ARDS? Who is at a higher risk of fat embolism?
I would say, I mean, I don't have scientific data to back this up, other than the patient with a wider canal will have decreased pressure while we're reaming. So potentially our intraoperative interventions will cause decreased amount of fat emboli from that patient. That being said, as you said, they have more fat in their canal, and probably they're less conditioned patient and maybe more unwell, so they may be at the higher risk of developing problems. But I think the most important thing is that both of these patients are at risk of having pulmonary problems during their care at any point.
Yeah, I think as our population is aging, we're seeing increasing numbers of patients at older ages, even very functional, but still, and some older that aren't so functional. I think it really starts challenging us to think about how we're going to manage them preoperatively and postoperatively and what sort of level of care. I think I have a really low threshold for patients like the second one you described, the 80-year-old with a fracture, perhaps a bit deconditioned up front, to actually throw more intensive resources at this person up front so we can try to identify early on whether this is the person that's going to have complications like a PE or fat embolism, or just be a little too oversedated because anything, a little bit of oxycodone, a little bit of morphine knocks them out, and be able to really get them up and moving. I mean, I think a lot of the complications, even if we don't have some of these really horrendous things like PEs and fat emboli, are the immobility, the difficulty in moving them towards having adequate pain control and moving them towards getting up and moving and out of the ICU, now the hospital, for their own benefit. So the more we can do to benefit that. And so we will often bring these folks into either an ICU in our environment or actually into some sort of higher monitor care so they can get actually that more intensive care up front, so we can try to identify when they're going to have these complications, since it's hard to predict, and then actually hopefully get ahead of it.
But it is fair to say that there is a subset of patients that is very susceptible to fat embolism that we still do not understand why or what specifically in their membranes or in their anaphylactic system makes them so susceptible to this.
And that's totally true. You can have exactly the same age, the same looking patient, same injuries. One does fine, the other has, you know, a really horrendous progression of fat embolism. It's almost the same scenario we see with just trauma of any sort. They can have the same sort of car crash, the same sort of injury pattern. One does well, the other has these horrendous pulmonary complications and other systemic shock. There's certainly a big body of work now throughout all of our systems and cross services to look at genetic predisposition. What is it, or how the environment, how they actually respond to trauma? What is it about some people that makes them higher risk? And I think one of the problems that we've had with some of these disease processes is it's very hard to define. How do I know exactly who had fat embolism versus just really a bad aspiration pneumonia or a bad complication from a transfusion? So it's hard to tease those out, but I think as we're moving forward towards sort of multidisciplinary research protocols that actually look at some of those risk factors, hopefully we'll have answers to questions like that in the next few years, so we can kind of predict who needs more care and how we might actually intervene to prevent the complications.
Knowing what you know, would it make sense, for instance, Daphne, to aspirate after we make a corticotomy in a patient's femur? Would it make sense to try to aspirate the marrow as good as possible just to get the loose fat out of there?
There has been some discussion about venting femurs or aspirating femurs, and that's kind of what the instigator of the Reamer Irrigator aspirator concept was. But we have to remember that when we ream fractures, we're also laying down good bone cells and bone morphogenic protein at the fracture site. So there's going to be a balance on whether these fractures heal with this type of treatment versus patient survival early on. And obviously patient survival is the key, but we also know that the majority of these patients will get better, and we don't want to have a whole series of non-unions of fracture. So this is something that's still finely balanced and certainly needs more work, but we're kind of at the early stages and the cutting edge of this technology.
I would answer Dr. Chapman's question is that I would be worried about the 16-year-old. Because they get fulminant respiratory distress syndrome sometimes when out of the blue. And a good example of that is that one day, probably in the early 70s, I came in on the Monday, and the chief resident had taken a patient in they couldn't operate on right away, a 16-year-old girl with a femur fracture, fairly simple, very healthy young lady, and he told her, well, we'll operate on you on Tuesday. And I went in to talk to him, and I said, I'm sorry that you're planning on an operation on Tuesday, but I'm very nervous about that because that'll be your third day in the hospital. And I explained all this stuff you've been talking about that I was afraid might happen. And they were disappointed, and I went back in the next morning. She was comatose and stayed that way for 3 days from fat embolism syndrome. And then later we nailed her femur, and she did perfectly. So those simple little rules that we had, getting PO2s and not nailing in the 3 to 5th day and using bypass reamers and so forth, kept us completely out of trouble. What I'm really thinking about is it's just sad that we don't all know the tremendous amount of work that was done in the late 60s and early 70s, which is the same thing you're talking about now 40 years later. So someday, it's my fault, I know, so someday I'm going to give a fairly good discussion about those things because they're very interesting, a lot of people involved. For instance, the study that was done at Dallas that you showed, the middle author there was a former Harborview fellow. The reason they did that study is because we wouldn't do it at Harborview. We wouldn't randomize. They would randomize because they had two different camps. Some believed you should do it and some believed you shouldn't. And everybody in our hospital was convinced that the way we were doing it was right and there was no way we would randomize. Not just me. It was everybody else, the ICU people, the surgeons. They didn't want to randomize, so it was left to the guys at Dallas who still had a debate to go ahead and do that study.
I would echo all the great work that's been done here. It's really clear to us, getting these patients in the ICU, that the work you guys are doing and have done for many, many years here is really front of the line and actually gets people to us in great shape and actually allows us to kind of just be part of the process to have them improve. So kudos to all the work. It's really remarkable being part of this process, and I think if we can identify some of these early predictors that can identify the young person who can get sick fast, the older person with comorbidities, we can only get better as we're going forward.
Well, thank you, Margaret. Thank you, Daphne. Thank you, Josh. And thank you all. Thank you. Great job.